So today you are keeping off from your busy clinical work.
Yeah,
Back to sessions, yeah.
yeah. But we'll start just after that.
Okay.
After meeting,
After meeting, okay.
we'll, yeah.
Okay. Yeah. Good day to all of you. And I'm Anid Patirana from Sri Lanka, Chair of the Prevention Council. On behalf of the Prevention Council of Symposium on lipids, lipoprotein, its role in atherosclerosis. At the Asian Cardiovascular Clinical Research Symposium of 2025. I think we have been regularly participating this biannual event as Prevention Council of AHS. And today, two of the deputy chairs of the Prevention Council, Dr. are joining with me for moderating this session. So let me first introduce the session. As you know, lipids are at the center stage of that management of lipid and lipid disorders are at the cornerstone in risk reduction strategies in reducing atherosclerotic cardiovascular events. So during this symposium, I think we can hear about various modalities, current and future modalities of targeting lipids for favorable clinical outcomes. I think let me invite Dr. Koji to introduce the first speaker for the day.
Thank you very much. I'm Koji Hasegawa from Kyoto. I'm going to introduce at the Vascular Research Division Department of Pathology, Harvard Medical School, as a postdoctoral fellow in the laboratory of Michael Gibbon. And now he was promoted to professor and chairman of the Department of Sciences and Bioethics. And also served as the chief in the Department of Medical Genetics. He's gonna speak. He's a very key important person in the field of atherosclerosis and lipid, and he's also serving as the vice president of the Japan Atherosclerosis Society, also the president of the Japan Cardiovascular Association. He's going to speak about the genome medicine for hypercholesterolemia, the present and future. Dr. Yoshida, please.
Okay, thank you, Professor Hasegawa, for kind introduction. Let me start my slides. Can you guys see my slides? Okay.
Yeah, you can.
Yeah, good.
And
Great. So let's start my talk. As Dr. Hasegawa introduced, I'm currently responsible for the genomic medicine department in my institute. And also, I'm interested in atherosclerosis, and my background is a cardiologist. So it's kind of a mixed lecture, but the genomic medicine or genomic testing is very important, not only in Japan, but elsewhere in the world. So let me start with the very, very basic concept of the genomic medicine. So most of you know that the DNA is coming from the nucleus of the cells, but sequencing technology is crazily developed, and the dramatic accumulation of genomic information made it possible to individual analysis of a genome sequence, which allow us to think about this personalized medicine. And usually this is tailored to the genomic information. So we can find genetic change, which leads to sometimes early diagnosis or selecting appropriate drugs, such as a cancer treatment. And also, because of this zillions of information, we can sometimes happen to find the secondary finding of the genomic information. Therefore, we need to be a little bit careful about treating with the genomic information. This slide summarizes the characteristics of genetic information should be considered when performing genetic testing and diagnosis from Japan Medical Association. And there is a unique character of genetic information, such as it doesn't change throughout the lifespans as far as germline sequence goes. And it's partially shared among relatives or families. And the genotype and the phenotype of relatives can be predicted with high accuracy. So before going to disease, you can find your future disease process in some cases. And it's also true with the prenatal situation. Prenatal diagnosis may be possible. Therefore, if handled improperly, it may cause social disadvantage to subjects and their relatives. So we need to be careful for dealing with genetic information. And this slide shows the next generation sequencing, which is actually the weapon for sequencing technology at the moment. The market is dramatically increasing. So the increment is like 13% from 2023 to 2030, and there's another new technology that's coming. So I think accuracy is much more progressed. In this situation, sorry to be shown in Japanese, but this is coming from our Ministry of Health, Labor and Welfare, so that's why they put in Japanese. So whole genome sequencing analysis initiative is started 3 years ago. So the Japanese government is officially now go to this genomic sequencing direction. So the government decided to check the tens of millions of Japanese population sequencing, and as I shown in my first slide, they would like to put into a precision medicine and high quality infrastructure for the genetic information analysis. And also that including some biobank systems for the future research. And sometimes in case of a genetic disease, we call it diagnostic odyssey for the rare disease. Because for the rare disease, not so many physicians know or see these kind of patients. So these rare disease patients have a very, very, very long, analysis, lab test, or treatment, which doesn't actually fit in his or her disease process. So this diagnostic odyssey can be shortened by genomic information. So this diagnostic odyssey is now becoming solving by genomic information technology. So for many people with rare disease, getting correct diagnosis can take years and lots of visits to different doctors. Therefore, we like to, somehow solve this very, predictive situation using genetic information. In these scenarios, the counseling technology is very important. Actually, I'm in the chair of the genomic medicine department, so we have 5 genetic counselors. So genetic communication should help the patient make their decisions within the context of the both genetic knowledge and personal choice. So we can review of testing that we offered and the explanation of possible result. There may be positive, negative, or VUS available with uncertain significance and the risk benefits. And of course, limitation of genetic testing and implication of test results for the patient and their family. And during this course of the government direction, in our country, there's a new regulatory requirements for the genetic and chromosomal testing. In this new classification, the genetic and chromosomal testing are classified as a primary items. Actually, so far, this genetic and chromosomal testing is a secondary items for the laboratory testing. However, from this 2018, the genetic and chromosomal testing is a primary item. So which means they are as important as other lab tests such as blood count or liver enzyme and so on. And also this primary items requires to qualify the standards such as ISO 15189 standards and clear. So actually the testing quality is dramatically improving in these 2-3 years. So I don't go in the further detail, but this new regulatory requirement such as the laboratory responsibility and accuracy assurance methods and documentation and reporting. There also clinical relevance is, of course, very important, especially for the FH diagnosis. I'm now, talk you in a minute. And in addition, there is a rapid growth of the reported genetic and chromosomal tests in Japan. The number of genetic disease that is listed in the medical fee scoring table, which means that it's covered by the national insurance, is increasing dramatically. In 2016, there's only 36 diseases that lab test is covered by the insurance. However, in 2022, it's 191 disease can be covered by national insurance. So even rare disease, you can diagnosed without so many costs. So it's covered by national insurance, which is very important for these rare disease patients. Okay, now I switch gear to the familial hypercholesterolemia, which is the most important and the most abundant genetic disease regarding atherosclerosis.
Asi?
Yes.
No, that's okay. Go ahead.
Okay, can I go
Yes,
ahead?
sure. Go ahead, please.
Okay, good. Thank you. So familial hypercholesterolemia, which is a very frequent disease. This homozygous familial hypercholesterolemia, we call it the HOFH, it's a kind of a rare disease. It's a 1 in 1 million. However, in a heterozygous situation, we call it a HFH. It's found in about 1 in 100 to 30, 100 to 300 people. So it's not so rare. You can find it in your, classmates, kind of, situation. And therefore, it's making it the most common genetic disease in this planet, so which is the most abundant genetic disease. The serum LDL cholesterol levels are markedly high, ranging from 500 to 1,000 for the HOFH, while in the HFH it's very widely rare. So it's in a minimum like 180, and a maximum is 500. So the diagnosis is very difficult without genetic testing. There are several unique symptoms like a xanthoma or Achilles tendon thickness. However, not all patients with HFH show this symptom. So the diagnostic testing for the genetic testing for FH is very important. However, you need to be careful in interpreting these results, especially in negative situation. because the sensitivity or positive genetic test rate is about 60% for the FH and 36% for the HOFH, which means that if the test is positive, which means that the person is FH, is sure. However, even if genetic test is negative, it may not rule out the FH diagnosis because this genetic positive rate is not that high. So it's slightly difficult to manage the clinical course of this FH patient. Also, FH is pretty much underdiagnosed and undertreated in the general population. This is a very famous Nordstad paper from like 10 years ago. The most diagnosed country in the world is the Netherlands. Netherlands is 71% of the FH population is diagnosed, so which is very high. In contrast, most of the country like Japan, Canada, United States, less than 1%, which means that the 99% of FH patients is not diagnosed. Although the LDL is high, so they receive some of the some kind of a treatment. However, it's not that pretty much diagnosed. And in a recent report from Dr. Tada from Kanazawa University showing that the number of clinical FH cases based on the LDL above 250 or above 175 with statin is like 10,000, 11,000. However, among the population, the diagnosed with FH is only 3,140, which means that only 3.4% of the total FH was properly diagnosed. This is, the real world data in Japan at the moment. So it's quite underdiagnosed. So which is very important for the genetic testing especially for the FH. There are several aspects why it's important. The first one is the confirmation of a diagnosis. Actually, this paper is coming from Canada, Ontario study, the clinical utility and diagnostic yield. This paper reviewed 11 clinical studies, and they found that if the person is diagnosed at FH, which improve the health outcomes compared with regular clinical evaluation alone, and increased statin dose or initiation of statin treatment or addition of ezetimibe or decrease in individuals remaining untreated. So this genetic cascade screening, which means checking the relatives of the patient, shows that FH 31% to 93% of relatives. So that this genetic cascade screening is also very important. Also, in this paper illustrates the economic evaluation. The genetic testing is a very dominant strategy and compared to the no genetic testing. Net saving approximately is 100 million over 5 years, so which is a very important cost cutting for their medical spending. And for relatives, both genetic and lipid screening are cost effective when compared to the no cascade screening. So in this Canadian paper, say genetic testing for the index case, which means the proband, the patient self, and also the lipid cascade screening for the relatives is recommended, which is, I think, the very reasonable at the moment. And also, in terms of risk stratification, both clinical signs negative, FH mutation negative, we call it a reference 1. So that if the clinical signs are positive, the odds ratio for the coronary artery disease is a 4.6, also 4 times higher. So it's similar to the clinical sign minus FH mutation positive. And if the both positive, which means that clinical sign positive and FH mutation positive, it's 11 times higher CAD risk, which means that not only the clinical sign but also the genetic testing make it very, accurate risk stratification. And there are several, calculation. I don't go into the detail about the Montreal FH score or safe heart risk equation or FH risk score. So using this kind of risk stratification approaches for the FH patients can make more accurate, predictive for the future ASCVD for this population. Also, the enhancing cascade screening for FH is very important. This is a genetic counseling, pilot study, which conclude that 40% of the relatives who is contacted or who is screened has a higher rate of this genetic testing after the first counseling. So the genetic counseling is very, important and effective. Okay, to summarize my today's talk, genomic testing significantly enhances the diagnosis and the management of familial hypercholesterolemia or FH. The genetic information has lifelong implications and is partially shared among relatives. And many FH cases remain undiagnosed and untreated despite clear clinical indicators. And the genetic counseling is very essential to support shared decision-making and improve patient understanding. Okay, thank you for your listening.
Dear Professor Yoshida, thank you very much for your excellent lecture. Because familial hypercholesterolemia, we have some kind of strategy against that to prevent the development of cardiovascular events such as coronary artery disease. So it's very important to perform more and detect more patients. The advocacy is needed. And is there any comment or question from the speakers or chairpersons?
So,
Yes.
Go ahead.
I need
Yes.
first.
No,
I'll
go ahead.
back to you.
Go ahead. You go ahead.
So, thank you very much for the very important topic. And I'm just curious about the epidemiology. I mean, the prevalence of the FH. I mean, the comparison between Eastern Asia people and the Western people. Yeah.
Yeah, I think it's very important. However, probably as it's very underdiagnosed, so the real number is not known. However, I think it's not so different among the ethnic background. So in Japan, as well as in China, as well as in European country, like 1 in 100 or 300 has this heterozygous mutation.
Mm-hmm.
So in any country, we should do the genetic testing if you suspect the patient might be FH or not. I think that's the point.
Okay, thank you. Thank you.
Okay, Anidu, do you have any comment? Yes.
Thank you very much for your presentation on this genetic testing important for precision medicine. So what age generally when the genetic testing is available freely or at low cost relatively, what is the age that you would recommend it for general population to be screened, because it's a highly prevalent genetic disorder?
Yeah, however, it's covered by insurance, but it's not so cheap, I should say. And we don't, recommend at the moment for the, entire population should be testing. Probably, pre-testing accuracy is becoming very low if the entire population is going to the testing. So I think it's important to screen or segregate the high-risk population, such as there are some family member has FH or a young CAD incident, or he or her LDL level is quite high. I think there should be some sort of pre-screening stage would be important because it's not that so cheap actually. Yeah.
Okay, thank you.
Okay, thank you very much for excellent lecture, Dr. Yoshida, and also
Thank you.
yeah, thank you very much for active discussion. Dr. Anidu, no, Ihang, please.
Yeah, okay. So our next speaker is Professor Li Jingliu from the Anzhen Hospital, and her topic today is about a very hot topic about RPA and atherosclerosis. Especially, we have some very important data from the Chinese cohort study. Okay. Do we have the introduction CV? Yeah. Professor Liu is from Beijing Anzhen Hospital, Capital University. She is the professor and also the director of the Center of Clinical and Epidemiological Research. And in Anzhen Hospital, she's also the fellow of ESC and the vice chair of the Health Information Task Force of Chinese Society of Cardiology as well. And has been published many, important research, especially on the epidemiology of cardiovascular disease in China. So please, Professor Liu.
Thank you, Dr. Sun, for the introduction. It's a great pleasure for me to be here to join this session. And yeah, first let me share my screen. Can you see my slides in full screen?
Yes, good.
Okay. Okay, so the topic is about the association between lipoprotein A and atherosclerosis in the Chinese cohort studies. We know that elevated lipoprotein A is a potential residual risk factor for ASCVD. Actually, the particle LPA is a compound by LDL-like particle with ApoB covalently bound to Apo small a. And there are mounting evidence showing that elevated LPA concentration is associated with increased risk of ASCVD. This is both supported by observational studies as well as Mendelian randomizations and genome-wide association studies. Given this evidence, the importance LPA is recognized globally. There are many guidelines and consensus statements addressing the contribution of LPA in the development and the prognosis of cardiovascular disease. In China, particularly according to our Chinese guideline on the primary prevention of cardiovascular disease, LPA is recommended as a risk enhancer or risk enhancement factors of ASCVD. As you can see here, we classified risk enhancers into target organ damage, such as coronary artery calcification score or clotted plaques or MT or left ventricular hypertrophy. And another classification of risk enhancer is serum biomarker, and LPA is one of them. But I think one of the characteristics about LPA is the genetic background is very strong, and there is a clear race and ethnic difference in LPA concentrations across populations. And in Asia, the prevalence of elevated LPA is much lower compared with Caucasians and Africans. How about the findings from population or clinical research in China? And first, there are some clinical evidence from patients. As we can see here, a paper published last year in JACC showing that LPA levels are associated with myocardial infarction in patients with stable chest pain. And you can see here, compared with low LPA level and absence of low attenuation plaque, patients with elevated LPA level and the presence of low attenuation plaque, which is showing vulnerable plaques, have substantially increased risk for myocardial infarction. And recently, a paper just published in Circulation, and it's a Mendelian randomization study conducted in both Chinese cohort and cohort from Europeans. And as you can see here, there's a clear association between the level of LPA and the myocardial infarction and ischemic stroke, but reversed negative association with hemorrhagic stroke. But interestingly, although it seems that Chinese people have, or all Asian people have lower level of LPA, but it seems that the association, the strength of the association looks similar across different populations. As you can see here, the relative risk in East Asians and European population are similar. That's some study regarding the LPA level and clinical events of cardiovascular disease. And our research is focused more early stage of atherosclerosis. Instead of studying the clinical events of cardiovascular disease, we particularly focused on the progression of atherosclerosis measured by B-mode ultrasound for carotid plaque. And this is a study published 2 years ago in Stroke. And we have a long-term cohort study in community dwelling adults in China. The study is called the Chinese multi-cohort study. The baseline was conducted in 1992. So this cohort has been followed up for more than 30 years. And in 2002 and 2007 and 2012, we conducted 3 re-examinations for the participants and measured their carotid plaques and AMT level. And in this study, we studied the LPA level in more than 800 adults in the cohort. And the outcome was the progression of plaque and the vulnerability of new onset plaque. And interestingly, we find that the elevated LP levels are associated with increased plaque burden. And you can see here a higher level of LPA are associated with more carotid plaques, the number of plaques, as well as the number of affected segments. And we also found that elevated LPA level was associated with the vulnerability of new onset plaques. And in the multi-variable analysis, after adjusting all other confounders, elevated LPA level was also associated with the increased risk of plaque progression and the risk of new onset plaque. And particularly for those people with LPA higher than 50 milligram per deciliter, it was associated with both plaque progression and new onset plaque. People with level higher than 13, their risk of new onset vulnerable plaque is also significant. And another paper, we studied whether the association between LPA with atherosclerosis is simply via atherosclerosis or independent of atherosclerosis. That means whether LPA has any other pathways leading to atherosclerotic cardiovascular disease independent of atherosclerosis. So we in this CMCS cohort, we have larger samples for more than 50,000 community adults. All of them measured LP level in 2007, and we followed them for more than 15 years. And the outcome was the incidence of ASCVD event. And first of all, we found that elevated LPA level was associated with increased risk of atherosclerotic cardiovascular disease. This was independent of carotid plaque. And also, similarly, the presence of plaque was also associated with ASCVD, which was also independent of LPA levels. And then we found a joint effect for both LPA level and plaque on the incident risk of cardiovascular disease. As you can see here, compared with those with lower LPA level and without plaque, and participants with either one of them abnormal or have elevated risk of ASCVD, but more strikingly, the participants with both high LPA level and with plaque, the risk was potentially particularly high. And lastly, go back to the guidelines regarding the LPA as a risk enhancer. We were interested in whether this LPA has any identical contribution or higher contribution compared with other risk enhancers in the development of ASCVD. So you also used this large cohort. We studied the contribution of each risk enhancer on the development of ASCVD, and we found that overweight and obesity, central obesity, and higher CRP and elevated LPA level, and this risk enhancers, both all of them have independently associated with incident ASCVD. And we also found that LPA, elevated LPA level, or the participants with more than 2 risk enhancers associated with increased risk of coronary heart disease, while overweight and obesity, central obesity, or multiple risk enhancers were associated with ischemic stroke. And we also found that the prevalence, the presence of multiple risk enhancers improved the discrimination, which was measured by C statistics. The area under the ROC curve was improved if the presence of multiple risk enhancers. And we also found that LPA level can reclassify ASCVD risk in adults with middle risk. In fact, more than 17% of the participants can be more accurately classified if we consider the presence of multiple risk enhancers. So in summary, cohort studies in Chinese community dwelling adults demonstrate that elevated LPA is associated with increased risk of ASCVD incidence. LPA promotes the progression of plaque and the new onset of vulnerable plaques, suggesting its causal role in ASCVD. And currently, clinical guidelines recommend LPA as a risk enhancer factor for ASCVD risk assessment to guide clinical decision making. So thank you very much.
Thank you very much, Professor Liu, for the overview of the LPA and especially the data from Chinese patients. And any questions or comments? So Professor Liu, so first I will kick off the question, and my question is that what do you think of the cutoff value for the prediction of ASCVD risk?
Yeah, that's a very important question. In fact, both cutoff of 30 milligram per deciliter and the 50 milligram per deciliter were used in previous studies. And at least according to our population studies, we found that the results were more coincidence if we use the cutoff of 50 instead of 70, instead of 30. But if LPA level is higher than 30, we did see increased risk of progression of atherosclerosis, although the evidence for clinical events was more profound if a higher cutoff like 50 was used.
Okay, thank you. No more questions?
Professor Liu, I have a quick question.
Go ahead.
Yes.
Thank you for
Go ahead, Professor Hua.
Thank you for the wonderful talk. So I think you have mentioned that LPA is a risk enhancer among all the other risk factors for ASCVD. So I just wondering, because of LDL cholesterol lowering drugs are the mainstream therapy, have you thought about, like, several ongoing trials are targeting LPA, like small interference RNA drugs? Have you thought about, on top of LDL cholesterol lowering drugs, we add on these LPA inhibitors? Do you anticipate it will have a much stronger effect, or is there any evidence available?
Well, I think when we developed the guideline in this session, we consider or we recommend LPA as a risk enhancer instead of included it directly as a core factor for risk assessment. I think the biggest obstacle is for the standard of clinical test, because if a marker or indicator cannot be standardized, we cannot use it directly as the primary target for clinical treatment nationwide, at least. So that's why. But I think with the development of laboratory testing methods, or and also with new therapeutic methods supported by clinical trials, I think LPA has a big potential to be included as a core risk factor or treatment target in the future.
So I think,
Thank you so much.
sorry, I
Thank you.
have a question. So in the absence of, this genetic testing for widespread use, so LPA is can it be used as a surrogate marker of genetic-based risk, especially patients who are for young patients for primary prevention having middle range LDL level, LDL cholesterol level, whether they need some sort of aggressive treatment for primary prevention. Number two, second situation that would be helpful is patients who are for secondary prevention, who has had a clinical high risk atherosclerotic cardiovascular events, but being treated with high intensity statin plus maybe ezetimibe, but still having a lot of residual LDL LDL cholesterol levels after after ensuring the adherence and adequate duration. That kind of people who are resistant to this our usual armamentarium, because these even inclisiran and things are not available wide use, especially in low resource setting like ours. So that might give an indicator about the genetic based, hereditary based contribution for this ApoB containing residual risk, lipid residual risk. That is my concerns or comments. What do you think that has a use in day-to-day practice in our setting like that? Measuring
Yeah, I agree with you that for some particular patient group, lowering LPA has more potentials. For example, those with low LDL cholesterol level but high LPA, when I think that's maybe more treatment target for this for LPA lowering therapies. But according to our cohort, although LPA has a very strong genetic background, but during because we have 15 years of 3 repeated measurements for LPA across 15 years, we do see a variation in the level for even within the same individual. So it's not solely genetic determined. Other risk factors such as obesity or inflammation also affected the level. So there are some potentials for this marker. So thank you.
Thank you. Yeah, thank you very much. I think we'll move on to the next presentation. It will be done by Professor Tilak Veeraratne. He's a professor of clinical medicine at the Department of University of Ruhuna, Karapitiya, Sri Lanka. And he's, I think, a clinician basically. But on top of that, he's conducting a lot of clinical research on various aspects, even epidemiology of the cardiovascular diseases. So I think he's going to talk about one of his piece of work regarding the use of statin for primary prevention of cardiovascular diseases in diabetes. Over to Tilak.
Yeah, thank you, Dr. Anindu. It's really a pleasure to be among you in a forum which mainly discusses high-flown stuff. Let me share some of the experience from a country which is not so high-flown, but we do have some concerns with regard to this primary prevention. So you all can see my slides?
Yes.
Okay. So the title of the talk was like use of statins for primary prevention of cardiovascular disease in diabetes. So in the next 20 minutes, I will just review the recent guidelines and evidence from clinical trials on primary prevention of CVD, and also present real-life data from Sri Lankan scenario based on a recent multi-center study. So you all know this, I suppose. Just recapture your memory. The patients with type 2 diabetes has 2 to 4 times higher risk of atherosclerotic cardiovascular disease, and ASCD with the leading cause. And the statins are the first-line lipid-lowering therapy available, especially in a country like ours. It is not only the first line; it is often it's a lifeline, because we do not have expensive treatments like monoclonal antibodies and others. Right, just to quickly go through the pathophysiology of cardiovascular disease, there are several factors involved, like endothelial dysfunction, chronic inflammation, and dyslipidemia comes in mainly the inflammatory part. And of course, when it comes to diabetes, there is also insulin resistance and glycation promoted plaque formation. Right. The statins come here because it's again, I think it discovered from the Japanese study. I am not wrong. It's discovered by Japanese for HMG CoA reductase inhibitor, and it has a lot of effects, mainly to reduce LDL, but it has other pleiotropic effects as well. So if you come to guidelines, the latest from American Diabetic Association says that moderate intensity therapy, statin therapy for adults between the age of 40 to 75 years, a high intensity statin therapy for if the multiple atherosclerotic cardiovascular disease or established atherosclerotic cardiovascular disease. And when it goes to American Cardiology Society and American Heart Association, they also have come out with the LDL-C reduction of more than 50% for very high risk individual, and also combination therapy with estimab. These are the main points in the recent guideline recommendation. So if you look at the clinical trials, there are primary prevention trials in patients with diabetic with statins. Now, you might see that they are pretty old, about 2 decades, but they have sort of some lessons. Now, the first two trials, CARDS trial in 2004 and ASPEN trial, they predominantly diabetic patients, and but there's a significant reduction in the primary endpoint. But the ASPEN trial failed to show any significant reduction, but the subsequent trials, including heart protection study with the simvastatin, they showed a reduction of cardiovascular endpoints right throughout. Now, some of these other trials like ASCOT and others, they have variable representation patients with diabetes, but in this subgroup analysis, they have shown that patients with diabetes do get a benefit more than the non-diabetic individuals. So that's the message that we learned from even the 4 studies, which I will show you next. And 4 studies also showed that there's a significant reduction in the major coronary events. And that is where the notion came that statin therapy is more beneficial in patients with diabetics in terms of reduction of cardiovascular disease than among the non-diabetic patients. Now, if you really rely on the evidence, I think meta-analysis are the most robust data in the literature. So it's a very recent publication, statin therapy and cardiovascular protection in type 2 diabetes, role of baseline LDL cholesterol level. Now, with the cutoff marks, cutoff LDL levels getting lower, and the targets getting further lower, does the baseline LDL level has any effect on the prime outcome among the statin trials? That is what these researchers have focused on as a research question. So they have gone through a lot of records, and they have screened finally full text articles 166. And so they have gone through these, and they've gone through their major atherosclerotic cardiovascular events, and then come out with this. I think this slide sum up a lot of things in my opinion. And when it comes to MACE, the major atherosclerotic cardiovascular events, there have been 9 studies, and 2 of them, the baseline LDL cholesterol is less than 100. And 5 of them, it is between 100 to 130. And there was a baseline cholesterol level of above 130 in 2. And you can see the relative risk reduction by statin therapy is more when the LDL level is less than 100, baseline LDL. To show that even if the baseline level is very low among patients with diabetes, the statin therapy is beneficial. Not only it is beneficial than those LDL baseline level is higher, about 130 or even 100. So when it comes to all-cause mortality, also it is same. That is, even at patients with diabetes with a lower baseline LDL, the benefit is bit more when compared to those who have a baseline LDL is higher. So this is the lesson that can be arrived at with this latest publication came in last year. Right. So with these clinical trials and meta-analysis evidence, one can come to a conclusion every 1 millimole of LDL reduction gives rise to about 20 to 25% of CVD reduction. And so these meta-analysis suggest that early initiation in moderate risk diabetic patient for primary prevention. So we know that the type 2 diabetes is once called cardiovascular risk equivalent. It needs aggressive lipid management from the beginning. Even if the baseline level is 100, the benefit is more. So therefore, primary prevention is one that is warranted. So we embarked on this study in several hospitals, 6 major teaching hospitals in Sri Lanka. Across the country, you can see there's one from the northern end, that teaching hospital Jaffna, one from the southern end, teaching hospital Gaul, and from the central country, from Kandy, and from the western, our capital city. So these are the teaching hospitals that were that participated in this study, and this is the publication. The statin use and low density lipoprotein cholesterol target achievement for primary prevention of ASCVD in patients with type 2 diabetes. This was published in early this year, and so just going through the objectives of the study, we wanted to assess the statin prescription patterns in patients with diabetes, because now, as we know, there's a statin prescription, there's a high intensity statins are indicated and recommended for category of patients, and there are moderate to low intensity statins are based on their cardiovascular risk. And we also wanted to evaluate their LDL target achievement and identify risk factors for the target failure. So it's a multi-center cross-sectional study, 6 tertiary care hospitals across 5 provinces in Sri Lanka. And there were around 2,000 patients with type 2 diabetes, and the lipid profiles were evaluated among the 683 of them. And the tools we used to categorize the cardiovascular risk is the WHO risk chart and the NICE and ADA guidelines for the cholesterol targets achievements. So we considered, this is bread and butter for cardiologists, you all, the low, moderate, and high risk, and LDL level of less than 100 for low risk people, and the target moderate to high risk people, we thought LDL target should be less than 70. Of course, the 50 didn't come because that is a very high risk. That was not considered here because it's a primary prevention we were mainly looking at. And we considered these are the 2 statins available in Sri Lanka to date, atorvastatin and rosuvastatin widely available, and atorvastatin 20 milligram, even though it is the 40 milligram for Western populations, and Sri Lankan and Asian populations, we have seen that 20 milligrams of atorvastatin does the job that 40 milligrams does it in other populations. Right, so coming to results. Now what this slide shows is statin use across the 3 categories of cardiovascular risk: low risk, moderate risk, high risk. Among the low risk, you can see majority have been on statin. Among the moderate risk again, but so across the 3 categories, statin use is quite acceptable, being a country with low resource setting, I would say. And so our overall statin prescription rate is about 84% above the all patients with diabetes for primary prevention. In my opinion, in our opinion and our experience, I think that is a fairly good prescription pattern. But when it comes to target achievement, it is not the same. Now, among the low risk population, 70% of the patients have achieved their target of less than 100. Moderate 62. As the risk goes high, the target achievement has gone down. So this is the most concerning point. Now, we can't be happy saying that the 84% of our patients with diabetics are receiving statins. They do, that's a fact. But are they receiving statins according to their cardiovascular risk is quite questioned here. Now, only about 50% of patients with high risk are receiving the target achievement. So they are suboptimally treated, and their statin prescription is quite suboptimal. Now, what are the risk factors for non-achievement? Female gender. Now, this is a universal phenomenon where the females are undertreated for various reasons, for their reproductive age and their other issues, and poor adherence. We have not gone into the exact causes for adherence, whether it is due to adverse effects or any other cultural taboos, but poor adherence is also fairly significant predictor of non-achievement of the target. And the poor glycemic control, that is also part and parcel of the whole attitude of patients with diabetes. If they are poor in their glycemic control, they are likely to achieve poor in their lipid control as well. And also the physical inactivity, and it is our countries like in Japan, we are slowly and gradually getting sort of mechanical and vehicle dependent, and so physical activity inactivity is also one important risk factor, significant risk factor for non-achievement of target in all these patients. So as I mentioned earlier, we can boast that 84% of our patients with type 2 diabetes are treated as a primary prevention measure with statins. But the intensity alignment, whether the patient with high risk are getting statins, we cannot be happy. So there's a over-treatment is low risk and under-treatment in high risk. And the main factors behind non-achievements are lifestyle and adherence play a part. So as a public health information, now we do have national guidelines based on perhaps from the regional guidelines. So we need now not only the guidelines for the patient, but we need to educate physicians on guideline adherence, because there's a lack of prescription. So the patient's cardiovascular risk category has not been properly assessed for them to be prescribed with high intensity statin. So the onus lies among the physicians, among the caregivers like us or like the other doctors who has not evaluated the patient's cardiovascular risk properly and treated them with appropriate doses of statin. So in this regard, we thought even electronic decision support tools are of use, like what is happening in the places where there's a much resources. So recommendations use truly high intensity statin dose when indicated, which is not happening. More than 50% of the patient with high risk, high ASCVD risk cavity in Sri Lanka across 6 teaching hospitals are not receiving the statin dose that they deserve. So improving the lifestyle modification programs. Now we do not have all the facilities like physiotherapists, dietitians, and each and every clinic. It is predominantly driven by physicians' prescription, physicians' advice. So we need some more diverse way of managing these patients. And also there's a little is done for medication adherence and monitoring. Even though it is prescribed, their adherence is quite questionable, because that also came as one of the risk factors for poor adherence. Now, these are the conclusions. 1/3 of moderate high risk patients receive high intensity statins, and nearly 50% failed in LCL target. And there is a strong need in a country like ours, where the cardiovascular diseases are getting into a pandemic situation, for policy driven statin use, not just statin to be given liberally, but a policy driven statin use. And thank you. And this work is based on this particular journal. Okay, thank you.
Thank you, Tilak, for that comprehensive overview about the ground level use of statin. I think that is the most widely used, available, still widely used agent, primary agent for lipid lowering therapy. So is there any questions from Tilak? We can give some time.
Yeah, thank you very much, Dr. Siriak. Yeah, I'd just like to ask you about the target of the LDL cholesterol crossroad. Do you think we should provide the statin for all diabetic patients, or for diabetic patients with LDL cholesterol more than 120 milligram per deciliter, or regardless of the LDL cholesterol levels, should we give statin for all patients? Is there any comment on that?
Yes, there was a suggestion that should all patients with diabetic be given statins. Now, based on what we have treated 84% of them, and we have come to very closer to 100%, like, but here the decision to give prescribe statin was based on their cardiovascular risk rather than giving universal. probably cardiovascular risk may have been assessed by presence of another cardiovascular risk factor, their age, and that sort of way, because albuminuria or hypertension or duration of diabetes, that may have prompted them to prescribe statin. To date, I doubt whether all patients with diabetes should be given a statin is still not universally practiced or universally recommended to my knowledge.
Okay, thank you very much.
So shall we move on to the next presentation?
Okay, so our last speaker for this session is Professor Hua Xinwei from the Peking University. And so the topic is, I think they have this group has just have a very good publication in the JAMA Cardiology to look at the association of ApoC3 and LDL-C lowering variance regard to the risk of coronary heart disease. I think this is related to the another hot topic about the triglyceride management. And yeah, so Professor Hua Xinwei is Associate Professor of Epidemiology in the Department of Cardiology, Peking University Third Hospital. I think he has been getting very good training in America, in the Emory University and Washington and MGH as well. And her research focused on the cardiovascular molecular epidemiology. So please, Professor Hua.
Thank you, Dr. Sun, for a kind introduction. So I will share my screen. For some reason, I cannot see. Can you see my screen?
No, not yet.
Okay, let me fix something. I think it's because they may not be able to record when it's going to. It's quit. Oh no. I probably has to restart. Do you mind if I quit and reopen Zoom and join later? Like 1 minute. Sorry, I didn't know my system has this.
It's okay. I think it's okay. Yeah. You can.
I'll try. Oh, I think it's working. Is it?
Yeah, it's coming.
Okay, great. Continue to share. All right, thank you for the introduction. And so today I will talk about the joint association of ApoC3 with LDL cholesterol lowering variants and the risk of coronary heart disease and diabetes. So this is based on our recent publications. And as we all know, like cardiovascular disease is the leading cause of death worldwide. And multiple lines of evidence, particularly from randomized trials, prospective cohorts, and median randomizations has shown that lowering LDL cholesterol levels is associated with a reduced risk of coronary heart disease. As we all know, as Dr. Thielak just mentioned, statin has been the first-line therapy for LDL cholesterol lowering drug. So the guideline has established it's been the primary target drug for both primary and secondary prevention of ASCVD. However, there have been some concerns about adverse events about statin, particularly with the increased risk of diabetes, muscle symptoms, and liver functions. So with these emerging, with the cornerstone statin therapy, as well as other emergent LDL cholesterol therapies such as PCSK9 inhibitors, there is still a residual CVD risk. And among those, high triglyceride has been one of the main concern. So we need to develop TG lowering therapies. And fibrates has been recommended as the first-line therapy for hypertriglycemia. And there is trial evidence showing that femifibrates, although it is it has efficacy in lowering TG, however, it has limited effect in lowering the risk of cardiovascular events. And there is also concerns about myopathies and liver damage. There is a need for novel targets. So ApoC3 is one of them. It has been shown it is a key regulator of the TG metabolism. It has the TG lowering, high TG, modifying TG concentration mainly through this lipoprotein lipase to reduce the lipolysis and the liver uptake. As a consequence, it will increase the circulating triglyceride levels. So from genetic evidence, there is a really wealth of genetic epidemiology studies using Mendelian randomizations or candidate genes approaches showing that loss of function gene variants of this ApoC3 gene has been associated with lower risk of TG levels and consequently lower risk of cardiovascular disease. Recently, there has been a large number of clinical trials, mainly targeting ApoC3, small interfering RNA drugs, and also this kind of is also an RNA targeting. It's called antisense oligonucleotide drugs. So multiple trials are ongoing. I have highlight a few of them. So Shasta is the plozasiran, is an SRN drug, which is targeting patients with severe hypertriglycemia, and it has tremendous effect in lowering both ApoC3 and TG. And they subsequently also targeting patients with mixed hyperlipidemia, that's the Muri trial, also showing a substantial effect on lowering TG and ApoC3. And another family is called, as I said, ASO drugs, taking alazocin as an example. It's targeted both patients with moderate hypertriglyceridemia and elevated CVD risk, and also those with severe hypertriglyceridemia. These kind of patients, and they show also in the ApoC3 levels as well as the TG level. Similarly, they have launched a phase 3 trial targeting patients with the familiar FCS patients. We also have seen substantial decrease in ApoC3 and a little bit fluctuation in the TG levels. So we across all these trials, we have noticed that these DNA or RNA targeting therapy has shown substantial effect in lowering lipids, especially TG. But there is lack of data on long-term effects. So that's one of the gaps in knowledge that we identified. And also on top of current cornerstone LDL lowering drugs, how about the combination effects? What if we combine statin with ApoC3 inhibitors? Will that has an effect in lowering lipid levels as well as CVD effects? So that leads to two of our objectives to look at individual effect of ApoC3 as well as the combined effect of ApoC3 together with LDL cholesterol lowering targets such as statin target HMGCR and PCSK9. So we have implied a study design called 2x2 factorial design. I will dive into in a minute, but the basic idea is we use the genetic variants to construct genetic scores, and then to evaluate the individual effects of ApoC3 with lipids and clinical outcomes. and consequently, we would investigate the combined effects of multiple drug targets to affect their drug response. So we used the data from UKB and included 400, a little bit more than 400,000 participants. And I will dive in a little bit about the study design. It's called factorial Mendelian randomization. I believe people are pretty familiar with Mendelian randomization and use genetic variants as a proxy of the gene, of the protein or the lipid level, and study its association with disease outcomes. So but the factorial design is a mimic of the factorial RCT design, as we have two interventions like drug A and B. And this is the traditional factorial RCT design. And similarly, we're targeting two genes. That's the factorial Mendelian randomization. So I think we have a next slide. So we basically combine the drug target MR approach using genetic variants as a proxy of the RNA or protein level to study its effect with the lipid levels and CVD levels. And the factorial design is we use ApoC3 genetic score, as well as we take PCSK9 as an example here. So at the end, we have mimicking 4 groups targeting, it's actually genetic inhibition, but mainly like a placebo group, PCSK9 inhibitor only group, ApoC3 inhibitor only group, or both inhibitor groups. So this is the a little bit background of this methods. So here is a little dive into how we construct the genetic score. So we use this drug target MR approach to pick the drug target gene, and we have selected genetic variants up and down 100 kb on either side of the target gene. And we have other criteria to further filtering the SNPs. And then based on the selected single nuclear polymorphism as SNPs, and we have this weighted GRS calculated using the formula below. So with that GRS calculated, so use it as an instrument to evaluate ApoC3 with lipids using linear regressions and with clinical outcomes such as CVD risk or diabetes risk using logistic risk. Similarly, when we do the factorial MR, we use both linear and logistic regressions for these different outcomes. So here is the baseline characteristic of the UKB participants. And we can show, mainly is to show these groups are stratified by the GRS score. So that, as I said, mentioned earlier, so this MR approach is mimicking the randomized trial. So we can see these two groups are the characteristics are pretty balanced in each of these two groups for ApoC3, for HMGCR, and for PCSK9. So as we can see here is the, to show the individual effect, mainly ApoC3, its effect on the lipid level. So we can see participants with lower genetic level, genetically predicted lower ApoC3 level. It is associated with lower TG and LDL and ApoB. And it's also associated with significantly higher HDL cholesterol levels. Excuse me. So when we look at each of these genetic targets with clinical outcomes, we found that for the coronary heart disease, all 3 genetic risk scores are associated with lower coronary heart diseases. And for diabetes, we can see lower ApoC3 is associated with lower risk of diabetes. However, the lower HMGCR is associated with an increased risk of diabetes. In addition, we conducted the 2x2 Mendelian randomization study, and this is the results. So combined genetic inhibition of ApoC3 and PCSK9 is associated with, we can see a trend of lowering TG, LDL, and ApoB, and we see a similar pattern for combination inhibition of ApoC3 and statin targets. And when we look at the CHD outcome, so combined effect of genetic predict lower ApoC3 and PCSK9 has an additive effect. So both inhibition has the strongest effect in lowering coronary heart disease risk. Similarly for the HMGCR. So we also, as I mentioned, single marker for ApoC3 is associated with lower risk of type 2 diabetes, and single lower HMGCR is associated with slightly increased risk of type diabetes. However, when we combine like both inhibiting ApoC3 and PCSK9, we have this mitigated effect of type 2 diabetes risk. So we also look at liver enzyme. So genetically lower ApoC3 and HMGCR had no adverse event on liver functions. So based on our findings, I think we have, it is inconsistent with previous genetic studies that ApoC3 inhibition is associated with a better lipid profiles and also as well as a lower risk of coronary heart disease. However, several trials demonstrated that ApoC3 inhibition slightly elevated LDL levels, as we see in here. So it actually highlights the need, maybe concurrent LDL lowering therapy is needed with ApoC3 inhibitors. So further, we probably provide the first genetic evidence on the long-term cardiovascular effect for ApoC3, as well as the combination therapy. And other TG lowering drugs combined with statin has shown some evidence. For example, niacin therapy does not improve cardiovascular outcomes compared with statin monotherapies alone. And also there are some side effects, such as myopathy was observed in the trial. Further, we also provided that genetically lower ApoC3 together with HMGCR, that's the statin targets, can mitigate the effect of type 2 diabetes. There are some small trials has been shown consistent results. So to summarize, our study has, using this factorial MR design, has mitigated the risk of confounding, reverse causation, and measurement errors that's been commonly seen in observational epidemiology studies. However, this is a limitation because we use genetic variants as a proxy of these inhibitors. It probably reflects more of a long-term lifetime exposure, which is different from these actual drugs that probably have a stronger and short-term effects. So in conclusion, our study finds genetically predicted lower ApoC3 was associated with a long-term reduced risk of CHD. And joint inhibition of ApoC3 and LDL lowering variants was associated with an additive reduction in CHD risk. And on top of statin target HMGCR, combined inhibition of ApoC3 has mitigated its effect on risk of type 2 diabetes. So based on our study, we hope it can provide some genetic evidence to inform future trials to evaluate the combination therapy of ApoC3 inhibitors and LDL lowering therapies, and also to further explore the safety of these combination therapy, particularly with diabetes. So that's all my talk, and thank you for your attention.
Thank you, Professor, for very. I think this combination phenomenon is quite interesting, and we all know that almost I think all kinds of medications targeting triglyceride has been investigated on the basis of studies. Yeah. So we don't know if there are any, maybe some mechanism, to explain why this this, the upregulation of LDL-C levels, and if the patient received APO3C inhibitor or antibody. So would you like to give some explanation about that?
Yeah, so just to clarify, I think you're asking, most of these trials has been based on a statin therapy, so they have a background. I think for most of this familiar FCS population, or those patient with severe hypertriglyceridemia, they probably not have a baseline statin, but I have to look. But on the second part of your question, for the mechanism underlying whether ApoC3 inhibitor is associated with an increased level of LDL cholesterol, that was indeed one of those, several of those trials results. I don't know exactly the biological mechanism, but I don't know if it's because ApoC3 is inhibiting the LPL process. So it might also affect the balance of these lipoprotein in the circulation level. So with the TG level goes down, whether there might be some kind of balance underneath. So I think that probably need further investigation.
Okay. More questions from our panels? Okay. So for the sake of time, so Anita, please give the closing remarks.
Yeah,
Okay.
I think thank you very much for everybody for participating, all the speakers and all the participants. It has been a very useful session to know more about the future, what is holding for the lipid lowering. And I think we are immensely benefited by the talks. Thank you very much for all the participants. We'll see you next time with our research symposium.
Yeah.
Thank you.
Thank you.
Thank you.
Okay, thank you very much.
Thank you very much. Bye-bye.
Yeah.